Everyone, this is our last week of talking about fats or lipids, and we're going to talk about essential fatty acids and eicosanoids. So our objectives are to identify and explain different forms of essential fatty acids and their food sources, identify the different forms of eicosanoids, explain the two main pathways involved in eicosanoid biosynthesis, and understand the relationship of essential fatty acids in different diseases. Now, most of the fatty acids we need in our body, we acquire from the diet. And the body is able to synthesize a lot of the fatty acids that we need for our biologic processes. However, we're not able to synthesize all of the fatty acid structures that we need. And these fatty acids that we can't synthesize are called essential fatty acids. They're essential that we get them from the diet because we can't make them. And these are polyunsaturated fatty acids, including omega-6s and omega-3s. So let's start with omega-6s. So our main omega-6s that are of concern to us are first linolate. So what these numbers here are telling us is first the number of carbons in the fatty acid and then the number of double bonds in the fatty acids. Okay, and sometimes I'll say something like linolate, or sometimes I might say linoleic acid, but same thing. For the purposes of this course, they're just different forms of the same substrate. We don't really need to worry about the difference. So linolate is the primary PUFA that we get in our diet. Then linolate can be converted to arachidonate or arachidonic acid. And this arachidonic acid is the main substrate for eicosanoid mediators, including prostaglandins, leukotrienes, and this should also say thromboxanes. Now we also have the fatty acid adrenate, number 3, and this is a storage form of arachidonate. And if we get too much arachidonate, then this adrenate can accumulate in our tissues. And then fourth, we have gamma-linolenic acid and dihomo-gamma-linolenic acid. And these are both intermediates in the pathway from linoleic acid to arachidonic acid. And we'll look at that more moving forward. Okay, and then we have our omega-3s, which we've all heard a lot about. So our most important, most essential, or real only essential fatty acid that's an omega-3 is alpha-linolenic acid. 18 carbons, 3 double bonds, ALA. And this is the fatty acid that is included in commercially prepared infant formula, typically, though more and more we're adding EPA and DHA also. Now, alpha-linolenic acid, can be converted into EPA, which is our major tissue component, and EPA can be converted into DHA, which is a major component of our phospholipids in our membranes, in our eyes, our cerebral gray matter, and in our sperm. And just take a quick look here. We'll look at this more moving forward, but ALA, which is 18 carbons, is converted to 20 carbons and then 22 carbons. And we also have 3 double bonds in ALA, but we have 5 and 6 double bonds in EPA and DHA respectively. And we'll look at how that works. Okay, so as we just said, there's 2 major classes of essential fatty acids. First, and each parent compound can give rise to longer chain derivatives inside of the body. So first we have our omega-6s here, which is our linoleic acid. This is converted to gamma-linolenic acid, dihomo-gamma-linolenic acid, and then our main biological substrate here, which is arachidonic acid. And you can see we do get some arachidonic acid just straight from the diet. It's not converted from our omega-6 linoleic acid. Okay, and then we have our omega-3s, starting with alpha-linolenic acid, eventually being converted to EPA, and then to DHA. So really, our alpha-linolenic acid is our real only essential fatty acid that's an omega-3, because really we can make EPA and DHA from ALA. However, we have very low efficiency in this conversion. So it's recommended that we obtain EPA and DHA from the diet. Okay, and here are our tables for our adequate intake of omega-6s. And the real number that you need to concentrate on here is that adults are supposed to get males are supposed to get 17 grams a day, and females 12 grams a day. So kind of keep these in mind, because I'll refer back to them in a little bit. And then for omega-3s, our adequate intake, notice that we do have that the source for all of these is ALA. Is ALA. And here, this is a really recent table. We have also EPA and DHA listed for infants, and that's because there is EPA and DHA in the breast milk, so increasingly we're putting them into a formula to mimic the breast milk. Okay, and the main numbers you need to look at here are 1.6 grams a day. That's considered an adequate intake for males, and 1.1 for females. And just also take note that these are adequate intakes. So we don't have a DRI because either it's considered that we don't have enough information, or we're just kind of slow in kind of synthesizing the information so that we can make a public health recommendation for intake. Okay, now omega-6s and omega-3s compete for the enzymes involved in desaturation and elongation. So what that means is, if you think back to that table that we looked at here, I'll just go back real quick. Okay, so the processes here to get from LA to AA and to get from ALA to EPA and DHA involve these desaturation and elongation enzymes. And so the W6s, or the omega-6s and omega-3s compete for these enzymes. So it really, the important thing when we think about diet is not necessarily the total quantity that we're getting of each of these, but really the ratio to one another. So we can eat a lot of omega-3s, but if we're eating way more omega-6s, then they're really not, the omega-3s aren't going to have the impact that we want them to have, because they're competing, they're going to be competing with the omega-6s, and so we won't really be able to utilize these omega-3s as much as we could. Now, we have different recommendations for what this ratio should be between omega-6s and omega-3s. And this is just kind of, this is from a 2015 article that's reviewing what all the recommendations are. And you can see that this ratio that's recommended is really low, sometimes as low as 2 to 1. Now, in the typical Western diet, we contain way less omega-3s than omega-6s. So the ratios that I typically have seen in the literature are either a range from 10 to 1 to 25 to 1 omega-6s to omega-3s. And you can see that's way above what our recommendations are here. And if you think back to those other tables where we were looking at what our adequate intake was, for females, it was 12 grams a day of omega-6s and 1.1 grams a day of omega-3s. So even our recommendations are really, for the general population, are really off of what we see the ratios should be for positive health benefits. Okay. Sorry, just trying to get organized here. Okay, so we talked about the numbering system, where we see, so one example is here, where we have 18, so linolenic acid, 18 carbons with 3 double bonds, okay? So that's kind of consistent here. However, we have 2 different numbering systems. The first is the delta numbering system, where it starts with the carbon 1 at the carboxyl end of the fatty acid. Now, the omega numbering system, just to confuse you, is opposite, where we start our counting of carbon 1 at the methyl end of the fatty acid. Okay, and then, so our example here is our linolenic acid, okay? So in the delta numbering system, it's showing, we have 3 double bonds, and it's actually showing us where these double bonds are, okay? So we're starting at the methyl end. No, sorry, we're starting at the carboxyl end, and we're counting to the 9th carbon, and it's saying that this is where the first double bond is, at 9, and then another double bond is at 12, and then at 15. So it tells us where these double bonds are. Now, the omega numbering system tells us where the first double bond is. So we still see that we have 18 carbons with 3 double bonds, but we're saying where is the first double bond? It gives us a little less information than the delta numbering system. So it's saying 1, 2, 3. Our first double bond is at carbon number 3. So it's an omega 3 or an N3. Okay, so and then we have our food sources of omega-6s. So these are mainly oils and nuts where we find our omega-6s. And again, these are very prevalent in the Western diet. But still, we don't want to think of linoleic acid as a bad thing. It's not a bad thing. It's just we need it in moderation in relative to the omega-6s. Okay, and then for our omega-3 fatty acids, here is our sources of alpha linolenic acid. So again, we have oils, especially canola oil and nuts. And then we have our food sources of our EPA and DHA, which are recommended because we have such low, or I guess inefficient conversion of ALA to these fatty acids. And just as we would think, we find them mostly in fish or sea life that is grown in very cold waters. And the one source that isn't mentioned here is human milk. So the mom is able to convert ALA to EPA and DHA, and therefore is able to provide these to the infant through the breast milk. Okay, so because it's hard to get adequate amounts of these with the Western diet, a lot of people rely on supplements. So ALA we would find in flaxseed oil or flaxseed or linseed oil. I'm just going to fix that little thing real quick before I upload it for you. Okay, sorry. And then we can also use supplements that contain EPA or DHA. So these are usually, the DHA usually comes from algae or fungal sources as well as from fish sources. And if you think about it, this makes sense. Where are the fish even getting this EPA or DHA? They're getting it from their food sources, which are typically maybe algae. Now we can also get EPA or DHA from cod liver oil. However, when we get enough cod liver oil to get us our adequate amounts of EPA and DHA, we actually get a really high dose of preformed vitamins A and D. So this is kind of a very active, more kind of hormonal forms of, or steroidal forms of vitamins A and D. So we really want to avoid that source in order, if we're just looking to increase our EPA and DHA intake. Now, all omega-3 fatty acid supplements are absorbed more efficiently with a meal, and you'll get higher bioavailability if you break up your doses throughout the day instead of just one taking it once throughout the day. And this can also decrease your risk of side effects. And when I talk about side effects, a lot of it is kind of digestive side effects. So a lot of people don't like to take fish oil supplements because they'll kind of burp it up and it's pretty disgusting for them, or it may cause them some sort of GI distress. So we can decrease risk of side effects by just breaking it up throughout the day. Now, fish oil is not all created equally. So you really need to look at the specific supplement when you're buying a fish oil supplement to see how much DHA and EPA it actually contains. And then we also have our gamma linolenic acid, which is, if you'll remember, is our omega-6. And people and sources of this fatty acid can be found in borage seed oil, evening primrose oil, and blackcurrant seed oil. Okay, so we've already talked about formulas attempt to add DHA and arachidonic acid, or DHA DHA, EPA, and arachidonic acid to mimic breast milk. And when we look at whether this actually works, as far as having the beneficial outcomes that we see from having these fatty acids in the breast milk, the evidence is really mixed. So some evidence shows that addition of these fatty acids to formula can be beneficial for visual, cognitive, and behavioral development, but some studies show no impact. So more and more companies are adding these fatty acids, which is great in case they do work. However, they are more expensive than the other unsupplemented formulas, and this can be really this can have a big impact on people, especially people who are low income and are purchasing their own formula. So we just kind of want to be knowledgeable about the impact before we recommend these things. So I just found a really recent article from 2014 that kind of summarizes where we're at in our understanding right now. And and it just basically summarizes the same thing. But says that, yes, breastfeeding is the best choice for infants, as we know. Breastfeeding women should get adequate DHA so that we have adequate amounts in the breast milk. And infant formula should contain DHA and arachidonic acid to provide these fatty acids for infants through the first year of life. Okay, so why are these considered essential? I mean, on a biochemical level, why are essential fatty acids actually essential? Well, linoleic and linolenic acids are essential because vertebrates lack enzymes to insert these cis double bonds at the N6 or N3 positions of the fatty acid. So this is analogous to saying the delta 12 position or the delta 15 position, because remember, we're looking at it from different directions. So these, so the enzymes that insert this double bond are called desaturases, and only plants have these desaturases. Vertebrates are incapable of forming double bonds beyond the delta 9 carbon in the fatty acid chain. So we're really out of luck when we're trying to insert these double bonds at the delta 12 or delta 15 places. We need plants to do it with us, for us, and then we need to eat those plants, or in the food system, one step up, the fish who eat the plants. So plants can introduce double bonds at delta 6, 9, 12, and 15, and therefore they can synthesize these essential fatty acids. Okay, so we don't really need to know too many details about how this desaturation and elongation occurs, but just that it does occur, okay? So this was taken out of that from the website, the Linus Pauling Institute website, and it looks a little confusing, but all you really need to know is that these FADSs are desaturase enzymes, and what these desaturase enzymes do is they desaturate the fatty acid. They add a double bond in. Okay, so remember back when we were looking, oh, actually, we can see it right here. Okay, so we have our desaturase enzyme, okay? So we can see here, we have 2 double bonds, desaturase enzyme, and then we have 3 double bonds. So it added a double bond, okay? So that's part of the conversion of our precursors to our kind of ultimate substrates of arachidonic acid, EPA, and DHA. And then we also have, so in addition to these desaturase enzymes, we also have elongase enzymes. In this, you don't have to know what this is, but just so you could understand what's going on here. These are elongase enzymes, and what these do is add 2 carbons onto the chain. So we can see here, we had an 18,3 omega-6, we have this elongase enzyme, and now we've added 2 carbons. So we have a 20 carbon fatty acid. So this is just the process that it goes to, desaturation and elongation, to get from these precursor essential fatty acids to our eventual products of arachidonic acid and DHA. Okay, so the principal eicosanoids of biological significance in humans are derived from 20 carbon fatty acids. Okay, so this is just and these play a critical role in immune and inflammatory responses. So both the 20 carbon omega-6, which is arachidonic acid, and the 20 carbon omega-3, which is EPA, can be found in cell membranes. Now, we do get some eicosanoids that are derived from EPA, but the vast majority of the eicosanoids are derived from arachidonic acid. Now, during the inflammatory process, these 20 carbon fatty acids are metabolized by enzymes to form eicosanoids. And the enzymes this formation of eicosanoids goes in two different paths. Okay, so we have our cyclic pathway and our linear pathway. And it's our cyclooxygenases that are the enzymes for our cyclic pathway, and our lipooxygenases that are our enzymes for our linear pathway. Now, as we talked about, if we're consuming a Western diet, the arachidonic acid found in the cell membranes is in much greater quantity than the EPA. And increasing our EPA actually decreases the arachidonic acid in the cell membranes. So then, so this is just kind of going back to the ratio thing that we were talking about, where if we decrease the ratio, which means we decrease the amount of omega-6s in relation to the amount of omega-3s, then we get more of the omega-3s in our cell membranes, and then we have a higher proportion of omega-3 derived eicosanoids compared to arachidonic acid derived eicosanoids. And we'll see why that's important. So, as I said, our major type of eicosanoids are prostaglandins, thromboxanes, and leukotrienes. Okay. So, prostaglandins and thromboxanes are collectively known as prostanoids, and that's because they were originally shown to be synthesized in the prostate gland. So that's just what they're called. And then thromboxanes were originally shown to be synthesized in the thrombocytes, hence their name, and leukotrienes from leukocytes. So this is where they get their names from. Now, the major sources of arachidonic acid is from the release of cellular stores in the cell membrane. With this, let me see what I'm trying to say here just a second. Okay, so we have this enzyme phospholipase A2, and that goes to our cell membrane basically, and the action of the phospholipase A2 is to release the arachidonic acid from our cell membrane. Now, if we don't have enough linoleic acid in the diet, it would threaten our body's ability to synthesize eicosanoids, and our eicosanoids are really important for different biologic functions. Now, eicosanoids do function locally at their site of synthesis. So through a secondary messenger system of G protein link signaling pathways, which activate our CAMP. So yet another process in which CAMP controls synthesis. So basically we have our hormonal messenger, which increases CAMP, and then that would cleave the arachidonic acid from the cellular membrane, and then that would be converted into eicosanoids, and the eicosanoids would have their biological action right at that site, that local site, where the arachidonic acid was released and converted to the eicosanoids. Okay, so we have two main pathways in eicosanoid biosynthesis. So we have our cyclic pathway, which produces prostaglandins and thromboxanes. And then we also have our linear pathway, which produces leukotrienes. And it's really the cyclic pathway that's the most biologically significant. sorry, I kind of rearranged my slides, and I'm a little bit trying to find where I am in my notes here. Okay. So the cyclic pathway is initiated through the action of the enzyme prostaglandin endoperoxide synthase. And this enzyme has two activities. First is our cyclooxygenase enzyme, and then our peroxidase enzyme. And this catalyzes the oxygenation of arachidonic acid with the cyclicization of an internal segment of the arachidonic acid chain. And this structure is a hallmark of prostaglandins and thromboxanes. So and when we consume NSAIDs, which are our non-steroidal anti-inflammatory drug like ibuprofen or aspirin, these act on cyclooxygenase activity. So they stop cyclooxygenase activity in order to prevent the production of prostaglandins and thromboxanes, and we'll see why moving forward. And here's just a pathway. So you don't need to know this in a lot of detail, but basically this graphic shows the synthesis of clinically relevant prostaglandins and thromboxanes from arachidonic acid. So we would have hormonal stimulus here, such as epinephrine or bradykinin, which is showed here. Okay, and that will eventually activate phospholipase A2. Okay, and that hydrolyzes arachidonic acid from the membrane phospholipids. And then we have our cyclooxygenase activity and our peroxidase activity, and then the ultimate fate, which is our all these different kinds or varieties of prostaglandins and thromboxanes. And then of a bit less biological significance is our linear pathway, which is initiated through the action of lipooxygenases. The enzyme 5-lipoxygenase specifically gives rise to our leukotrienes. So corticosteroid drugs act to inhibit phospholipase A2, which inhibit the release of arachidonate from membrane phospholipids and the subsequent synthesis of eicosanoids. So here we have our linear pathway, same thing. We have our input here of bradykinin, and which again releases the phospholipase, or activates phospholipase A2, which releases it, and then we have our 5-lipooxygenase enzyme, which helps us to synthesize our leukotrienes. Okay, so the cyclooxygenase pathway can convert EPA to DHA and EPA and DHA to prostaglandin I3 and thromboxane A3. So these both contain 3 double bonds. But EPA competes with arachidonic acid for incorporation into tissue lipids. And this includes the phospholipid pools that supply the substrate for eicosanoid synthesis. Now, when our phospholipases are activated by hormones such as epinephrine, there's less arachidonate in phospholipids for release, and therefore reduction to arachidonate-derived eicosanoids. So really, if we think about it, if we get more omega-3s, we get more omega-3s that are incorporated into our cell membranes, and therefore, when we have the phospholipase A2 or the cyclooxygenase, which is kind of one step further down, they're less likely, when they go to release a fatty acid, they're less likely to release this arachidonic acid from the cell membrane. So in this kind of indirect way, EPA is an effective inhibitor of arachidonate metabolism into arachidonate-derived eicosanoids. Now, EPA-derived eicosanoids, which remember, that's kind of minor in comparison to our arachidonate-derived eicosanoids, but our EPA-derived eicosanoids play a vital role in our immune function, even though the amounts formed are usually really small. So, and they do this, again, kind of indirectly. They do this by preventing excessive production of these arachidonate-derived eicosanoids, and therefore preventing the action of these arachidonate-derived eicosanoids. So in that way, EPA fine-tunes the intracellular signaling process and reduces the arachidonate-derived eicosanoids mediated response, such as inflammation. So in this way, EPA really has an action of inhibiting inflammatory processes so that they don't become uncontrolled. Okay, so this is kind of just putting together what we saw. So we have our arachidonic acid. Okay, so sorry, we have our cell membrane phospholipids. We have our phospholipases that remove the arachidonic acid from the cell membrane, and then we have our arachidonic acid, okay? So it can go one of two ways. It can do the linear pathway with this 5-lipoxygenase and produce these leukotrienes here. And if you'll look at this, these varieties of the leukotrienes cause vasoconstriction, bronchospasm, and increased vascular permeability. Okay, so these are all kind of, think of like inflammation or the body having really an immune response, like having trouble breathing, for instance, with the bronchospasm. Okay, or we can arachidonic acid can take the cyclic pathway where we have cyclooxygenase that is converted into prostaglandins and eventually into all these different types of prostaglandins that have different actions. So, whereas prostaglandin, the prostaglandin I series does cause vasodilation and inhibits platelet aggregation, the prostaglandins D and E also cause vasodilation, but also cause increased vascular permeability. And then we have our thromboxanes here, which cause vasoconstriction and promote platelet aggregation. So we kind of have all these different actions of these eicosanoids, and they all have I should say, they can all be useful in certain circumstances. However, if they get out of control, then it can be a problem. We can have this kind of uncontrolled inflammation. So this graphic is demonstrating, basically putting together everything that we've talked about. So we have our precursors here. They go through these enzymatic changes of desaturation and elongation. And then it's showing that what happens ultimately to these intermediates and final products. So here we can see that this intermediate dihomogamma linoleic acid actually results in prostaglandins and thromboxanes that are considered the 1 series or anti-inflammatory, okay? And then we also have these products EPA, which undergo the cyclic and linear pathways and result in these eicosanoids that are the 3 series and the 5 series. You don't need to know the numbers, but just know that they result in eicosanoids that are considered anti-inflammatory, whereas arachidonic acid is converted into thromboxanes that we consider to be pro-inflammatory, okay? And this can result in cardiovascular, neurologic, and inflammatory disorders. And it's showing kind of a different pathway here where EPA is eventually converted to DHA. And again, this has results in anti-inflammatory, not necessarily eicosanoids, but molecule substrates that also have an impact on cardiovascular, neurological, and inflammatory disorders. Okay, so our polyunsaturated fatty acids are components of cell membranes, and these impact the properties of the cell membrane, including the fluidity, flexibility, permeability, and enzyme activity of the membranes. Okay, so we know that ALA in our cell membranes, their main function is that they're precursors for the active EPA and DHA. Okay, so but our function of, so I guess when I say functions, I mean in addition to impacting cell membrane activity, we have these functions. So ALA is a precursor, and then DHA, which is kind of our ultimate product from ALA and EPA, has a few very specific benefits. So first, we know that it impacts our vision. So DHA is found in high concentrations in the cell membranes of our retina, and our retina conserves and recycles DHA because it's so vital to the function of our eyes. So there's really kind of this system in place to conserve and recycle this DHA. And it's DHA is required for normal development and function of the retina. So researchers have found that DHA deficiency during critical periods of retinal development can result in permanent abnormalities in vision. Okay, and then again, in addition to the impact on membrane properties and vision, we know that DHA also has function of brain function, is also plays an important role in brain function. So from animal studies, we see that DHA depletion in the brain does cause learning deficits. And DHA can alter brain function by altering the ion channel or membrane receptor functions and neurotransmitter activity, though we don't really know exactly how this works. Okay, so next I want to talk about essential fatty acid deficiency. But before I do that, I want to talk about a couple of definitions that I'm going to use, of words that I'm going to use in this discussion. So another way to classify these fatty acids are by the number of double bonds in the PUFAs, but these categorizations are a triene or a tetraene. So triene has 3 double bonds. We normally have very little in our plasma, and tetraene has 4 double bonds. And our primary tetraene is arachidonic acid, and it's normally about 8 to 10% of our plasma fatty acids. Now, our normal triene to tetraene ratios is really low, just about 0.1 to 0.2, because we don't really have many trienes in our plasma ordinarily. So we have a really low ratio. However, when we have an elevated triene to tetraene ratio in the plasma, it's usually a sign of essential fatty acid deficiencies. And this is indicating that our plasma levels of linoleic and arachidonic acids are low. Okay, so if our tetraene, our 4 bond structures, are decreased, then our ratio decreases. And that's showing that we just aren't getting enough of these essential fatty acids. Now, when we have essential fatty acids, we see that the omega-9 ETA here is present. Now, normally these aren't present, and this specific omega-9 is an abnormal byproduct of oleic acid desaturation. So if we're not getting enough omega-6s, then the arachidonic content of the plasma is decreased and is replaced by omega-9s. So then that gets converted to this omega-9 ETA, which is why we see that it's present in essential fatty acid deficiency. So measurement of this ratio is one test that can be used to diagnose essential fatty acid deficiency and has been used to diagnose this condition in patients with fat malabsorption or trauma or burns. So one place that we might see essential fatty acid deficiency is in full-term babies that are fed skim milk formula that is low in linoleic acid. Okay, so this is really why we say if you're not going to breastfeed, you need to formula feed. And I don't, skim milk formula, yes, maybe we've seen this in the past, but this is not in practice now. Now we know that these fats are really important for infants. So if a baby is fed this skim milk formula, they can have growth failure, thrombocytopenia, alopecia, and scaly dermatitis because of the increased permeability in the skin and water loss from the skin. But when we supplement these infants with linoleic acid, the symptoms go away. So deficiency of essential fatty acids is unlikely to occur with a balanced diet, although cow's milk only has about 25% of the linoleic acid in human milk. It's still adequate. And we see that, even in countries where maybe food supply isn't as adequate as it should be and fat intake isn't as adequate as it should be, that the fats being consumed are actually more likely to be of vegetable origin than the fats that we consume in the Western diet. And fats that are consumed from vegetable origin are more rich in linoleic acid and some linolenic acid. So even though there's lower fat, there's higher proportion of these essential fatty acids. And this is why we really don't even commonly see these essential fatty acid deficiencies even in locations where you would think we might see these because of inadequate food supply. So essential fatty acid deficiency did used to be a hazard with TPN, but now we know this and we use fat emulsions and we can prevent this deficiency. Okay, so the cell membrane fatty acid composition can be altered by modifying dietary intake, just like we've talked about. So the fatty acid composition of most membranes adapt to some extent the type of fat that is available in the diet. And the only organ that's resistant to such diet-induced changes is the brain. So one example is, so other than the brain, if we have a diet that's rich in sunflower oil, which is 70% lineolate, then this omega-6 PUFA content in the membrane phospholipids will increase, okay? And this is counterbalanced by a decrease in the omega-9 content in order to compensate. So with our PUFAs and our MUFAs, basically we are incorporating these into our cell membranes, but our body knows enough to, okay, when we put this PUFA in, we need to take this MUFA out because we don't want to have excessive membrane fluidity. It's good to an extent, but we can overdo it. So our body kind of has that natural check and balance. So just very briefly, I want to talk about cystic fibrosis. Fatty acid metabolism alteration is a very well-known phenomenon in cystic fibrosis patients. And some of these alterations in fatty acid metabolism include decreased linoleic acid and DHA, and increases in this palmitic acid and this meat acid. So basically what you need to know is that the alterations mean that we're getting, these patients are replacing their essential fatty acids and instead are with non-essential fatty acids. Okay, now what are our physiological effects of our prostaglandins? So prostaglandins play a key role in inflammatory response. So biosynthesis is, when biosynthesis of prostaglandins is increased in tissues, we demonstrate the kind of cardinal signs of acute inflammation, okay? So administration, and so we see in research studies, when we administer these specific prostaglandins, these prostaglandins E, they induce signs of inflammation. So they cause redness and heat and swelling and edema. And so the redness and heat is due to vasodilation, and the swelling and edema is due to increased capillary permeability. Now, prostaglandins can also have a physiological effect on reproduction. So we know that prostaglandins used to be used for medical termination of pregnancy. So when I say medical, I mean versus surgical. And they are still used in combinations with other drugs for this purpose. We also know that prostaglandin E is upregulated in endometriosis, which is the leading cause of infertility. And it's also been suggested that these prostaglandins may play a role in male infertility. But I couldn't find really much recent evidence of that, so I'm not sure if that is still a viable hypothesis. Now, we also know that some of our prostaglandins are vasodilators, which lower systemic pressure and increase blood flow and decrease peripheral pressure. So the thought is, if we can isolate these prostaglandins or produce these prostaglandins in maybe a laboratory setting for a medication, maybe they could have a positive impact on hypertension. The tricky thing about prostaglandins is that we don't quite understand them fully. So we know that they're present when we're having these inflammatory reactions, but we really don't know if we can control the prostaglandins, if we can consequently control inflammation. It's unclear. Now, can we get too many omega-3s? And this is a very relevant question right now. I'm sure, I know I try to take omega-3s, fish oil, I rarely remember, but we just hear, especially in nutrition, so much about the benefits of omega-3s, especially for inflammation. So can we overdo it? Well, for ALA, which we usually get from flaxseed oil, high doses can have some detrimental side effects like loose stools or diarrhea, or some people could have an allergic reaction. But generally, the side effects are really minimal. It's considered to be well tolerated. However, EPA and DHA are associated with detrimental health outcomes, really, if they're overconsumed. And these detrimental outcomes include impaired immune function, bleeding, and increasing risk of hemorrhagic stroke and oxidative damages. So we talked about, if we incorporate these omega-3s, then we'll get less of these arachidonic acid derived eicosanoids, which cause inflammation. And this is really good. And especially for those who may have an autoimmune disease where you do want to suppress this inflammation. However, we have inflammation for a reason. And that reason is that our bodies are saying that we need to destroy the pathogens or the source of this inflammation. So therefore, if we don't really want to, if we take too many omega-3s, we could suppress our immune system beyond what is desirable. Now, overconsumption of EPA and DHA is also associated with increased bleeding. So a lot of times for directions when people are going to have surgery, they'll say, okay, ahead of time, stop taking your omega-3 supplement because this is just going to increase your risk of bleeding. But the United States FDA said that intakes of up to 3 grams a day are considered to be safe and unlikely to cause clinically significant bleeding. And then our final negative impact of overconsumption of EPA and DHA could be oxidative damage, okay? So because EPA and DHA have double bonds, this is a lot of what is beneficial about EPA and DHA, but it also makes them vulnerable to peroxidation. So we have these double bonds here, okay? But if one of the double bonds breaks, basically, then we have these reactive oxygen species. So we have this unbound carbon here, and that reactive oxygen species can lead to kind of this, like we've talked about in past lectures, this kind of downhill reaction. So basically, think about one of these in your phospholipid bilayer, okay? So we have oxidation of the EPA and DHA. We have a reactive oxygen species, and then that reacts with the lipid next to it, and that reacts with the lipid next to it, and then we kind of could have this even unzipping or dysfunction of our membranes. And this, so basically it results in oxidative damage of various tissues. Now, we know that EPA and DHA definitely undergo this lipid peroxidation ex vivo, but it is really not clear how much this occurs in our body. Okay, so, and then this is kind of a little bit of a graphic here. So here's a membrane phospholipid. This is a saturated fatty acid. This is a PUFA here. Okay, so we have our double bonds here, here, and here. And then these are all completely saturated. But if we have a reactive oxygen species that interacts with our phospholipid, our double bond here, okay, then it can actually kind of break off part of this fatty acid, and then we have another reactive oxygen species here that can react with another fatty acid. So the oxidative damage is, the recommendation, I should say, to reduce oxidative damage is to consume with the fatty acid an antioxidant, such as vitamin E. And again, it's kind of unclear how effective this intervention is in decreasing lipid peroxidation. So this is all kind of theoretical. And here are your practice questions. All right, everybody, have a great week.